All right, so it's 2 o'clock. I think it's time for us to go ahead and begin the session. I want to welcome you all this afternoon. My name is Kristen Baugnon, and I'm a neuroradiologist from Emory. I want to welcome you to our SAMS session on career well-being, kind of going along with our theme of the meeting. So you should all have gotten your little SAMS things when you walked in. You can use your little QR reader or go to the URL on the website. And you need to make sure to answer the questions during this live session to be able to get credit. Okay, so we're going to go ahead and get started. And without further ado, I'm going to introduce you to Dr. Chetlen, Alison Chetlen from Penn State, who's going to talk to us about professional and career resilience, avoiding burnout, and the art of reinventing yourself.
Hi, everybody. Welcome. I don't have all the answers here, but this is what I hope to achieve with the talk. We're going to quickly talk about defining burnout and list some individual approaches to foster resilience and prevent some burnout symptoms, and then apply some strategies to reinvent yourself. So the background is, we all have heard a lot about this. This is the topic of the meeting this year. Physician burnout continues to climb. It in 2012, it had increased 10% over 3 years. And in just the 2018 Medscape National Physician Burnout and Depression Report, 45% of radiologists surveyed had experienced some surveys. We know that burnout is classified by exhaustion, cynicism, and reduced effectiveness. What I'd like to talk about is how to kind of turn the tables, talk about how to become more engaged. Engagement really implies vigor, absorption, and dedication to your work, being very passionate about what you do. The reason this is so important is because we know that burnout can cause both personal and professional problems, broken relationships, alcoholism, suicide, physician turnover, which is detrimental to hospitals and organizations, decreased patient satisfaction and patient errors, decreased quality of care. So there are some ongoing national initiatives, and I only bring these up only because I think that they are, although they are a national initiative, there are a lot of opportunities to get involved on an individual level. The National Academy of Medicine has one of the largest national initiatives ongoing right now. They have an action collaborative on clinician well-being and resilience. They have a number of task forces which are really looking, and they're diving very deeply into certain aspects of physician burnout and wellness. And as of January 11th, 2018, more than 130 organizations had joined this collaborative. And the organizations aren't just hospitals. These are medical systems, universities, professional societies, even insurance companies. The ACR is there representing us, by the way. This is a great opportunity to discuss and share their plans of action. I attended their meeting in 2017. It was held in DC. It was an open meeting. Public members can attend these and get involved on an individual level. So I encourage you to check that out. Something else I'm involved in is the Institute for Healthcare Improvement, the IHI. They have an open school, and they run certain courses. They also have blogs, they have networks, online networks, and different projects. I'm involved right now in a 12-week certificate course. It's called Finding Joy in Work course. I think this is a way to become involved individually on a more national scale. And this is not just limited to our country. This is an international. So I'm able to collaborate with colleagues from all around the world, which is actually very inspiring. It gives me some hope, and we're all trading secrets. So aside from organizational solutions, which you're going to hear about a little bit later, we really need to focus on how to find fulfillment within work and not just how to escape it. So I'm not going to be talking about what to do kind of outside of work. Some individual strategies here. You may have heard something called learned optimism. Has a bunch of different synonyms. Appreciative inquiry is another one. We know that optimists are more successful, they're confident, they kind of see that glass half full. It's important to make a concentrated effort to see the glass half full. Look at defeats not as reflective of life as a whole, but just kind of a speed bump, a transient bump to get over. Connection is really important. We know that radiologists are a little bit more risk for that feeling of isolationism, sometimes due to geographic clinics or geographically where your reading rooms are located. There is this fundamental need as humans to kind of feel a part of a tribe or a bigger community, and it's really important to make a concentrated effort to make some connections, whether it's with your colleagues, with your patients, with your peers. So ways to strengthen team relationships. I just inserted some things that we do, and I don't claim to have all the answers, but we are known, and specifically maybe me, for playing some practical jokes on my colleagues. And here, one of my colleagues went on vacation, and she left behind a pair of shoes that she frequently performs biopsies in. And so we took the shoes for a tour. We probably took about 50 pictures of her shoes all around the town, went to baseball games. It went and looked out on Harrisburg here. We took mammograms of her shoes, and we wore her shoes. We took turns. So, we do this all in good fun and good humor, but really strengthening team relationships is important. We also try to go out as a group. We tend to kind of celebrate our techs and our nurses and our technologists, and this is just a picture of some of the people that I work with. We go out for dinners once in a while. We engage in meaningful work, and this is really important. You've heard the statistics. If you are involved in work that brings you real, true satisfaction, and you're very passionate about it, 20% of the time that your life will be better for it. You'll be a little bit more well. So whatever your meaningful work is, find that and kind of hold on to that. This is me. I've become interested in some advocacy, and we invited a legislator to view our breast center, and this is just a picture of us doing some meaningful work. So how do you foster resilience? It's not easy. Resilience implies this wholehearted engagement, not a withdrawal from, but the often harsh realities of the workplace. We know that burnout is best tackled from an organizational approach. Some of those things are out of our reach. We still have opportunities to help out by engaging our leadership, but as far as individually, this is what this talk is about. Practicing self-care is important. We know this is common sense. Eat well. Find someone to hold you accountable. Find a close colleague or confidant who will hold you accountable and kind of check in on you from time to time. Getting enough sleep and exercise. Easier said than done. Don't be afraid to reach out. Watch for symptoms of fatigue, change in appearance of a colleague. You kind of get that gut feeling if something's not right. Don't ignore it. Reach out. Kind of dig a little bit deeper. We're all in this together. Mentoring is also helpful. Mentoring and being mentored, both ways. Mentoring younger physicians brings a lot of joy to me personally, and I've seen it kind of work both ways in colleagues. Peer mentoring is really effective. It creates kind of a strong sense of collegiality. It can give you a broader community at work, and it provides both professional and psychosocial support. So good leaders shouldn't take you on a roller coaster ride. This is one of our roller coaster rides in Hershey, PA. So good leaders, their work will be kind of a roller coaster ride, but it shouldn't be these kind of sudden highs and sudden lows. Communicate well and encourage others to find new ways to solve problems. Engage your leadership. Try and be an active participant within your organization. Reading room environments. This is where we work primarily. It should be kind of a nice place to be. So some things that we've done is we've tried to improve ergonomics in our reading rooms by getting some fancy chairs, making sure they're clean, they're comfortable, they're aesthetically pleasing. So you can change the reading room setup to a degree to help strengthen the team relationships. We sometimes hold RADPath conferences in our reading rooms. But with organizations increasing in size, it can become a little more difficult for us to interact with our colleagues and referring physicians. So we try and make our reading rooms kind of an inviting place. We have signs on our door, knock and come in if the door is closed. Or if it's wide open, we invite people to come in and collaborate with us. Having independence and control or autonomy is really important. Discussing with your leadership if there are possible flexible work options. I'm not suggesting at all reducing a professional work effort. In fact, in a Schoenefeld study evaluating physician burnout and changes in professional work effort, they actually found that high burnout and lower satisfaction scores correlated with actual reductions in the full-time equivalent physicians. Another way to reduce burnout is to give honors and awards and recognize people that are important in the workplace. We're all important in the workplace, but kind of having that pat on the back and receiving those awards are important. And I'm not just talking about your physicians, but really engaging the entire staff here. This is us kind of celebrating. We had a staff celebration for patient satisfaction. Find some wins and involve the staff to, kind of strengthen the sense of community. And if it ever comes to a point where you feel like you're spinning out of control, don't be afraid to seek professional help. And I talked a little bit about getting involved at a national level and how to do that. Oftentimes it's a quick email, it's volunteerism. You can join committees, there's task forces, there's webinars, there's virtual conferences, and even social media conversations where you can get involved. So the second topic of my title, when I was given this, they said, talk about how to reinvent yourself. So I definitely don't have all the answers here. When I thought about how to reinvent yourself, I thought of two different scenarios. So there's the late career, reinventing yourself. We don't really have a lot of knowledge about this. Career transition experiences can be, we know, very difficult, especially for the older radiologist who's considering retirement or cutting back on their FTE. We need more research. We don't know about the psychosocial adjustment and the well-being of someone who's been involved in academic medicine for so long as they plan for partial or complete cessation of their work activities. We know that being an academic radiologist is part of our professional identity, which can be a very big component of who we are. For many, our occupation identifies us as productive members of society. It defines our social status, our area in which competence can be demonstrated and praised. We're an expert somewhere. It gives us specific goals, and it kind of gives us structure and meaning to our day and to our year and to the future. So, reinventing yourself, I could give you my story, but what I thought would be better was I polled a variety of clinical radiologists from around the country in different stages of their careers, and I asked them, how have you reinvented yourself, and how do you prevent burnout? And these are some of their answers. Maintaining outside interests, no matter what the cost. Burnout for me results from lack of control and a lack of respect. Reinventing comes from being gentle with myself, realizing that I may not be responsible for controlling the situation and that the lack of respect may not be my fault. I have been learning the ukulele over the past year and reading music theory. You can see from these responses that lots of different scenarios can work for different people. I remember to count my strong foundation and my many blessings, including a stimulating and rewarding career, good friends, and family. I try to remember to use my resources when the winds are changing, shift. Thank you, Bob Dylan, and smile a lot. When struggling with my own sense of control in something that I cannot affect or change, I try to embrace the helplessness and then release what I cannot control. Let go or you will be dragged. Learning to say, I need help, especially at home. Involvement with global health imaging has been really good for the soul. I have dabbled in mindfulness activities and readings, which I have found helpful with focus during a busy day, but I have found centering and grounding from spiritual and musical sources, routine prayer, and Bible study. Remembering that you're not the average person, not to sound snooty, you can't expect yourself to do all the other things that non-physician women do. Learning to say no after you've established yourself. Remind myself of the power of being resilient. A winner is just a loser that tried one more time. Sometimes you just have to move on. Moving on is not failure. Finding joy in something that brings joy to your life in any measure. Be grateful inward and outward helps acknowledge the support of others and one's own accomplishments to bolster resiliency. Not being thin-skinned has been the backbone of my resiliency and the ability to reinvent myself, or rather, just continue to grow in a new direction. Be conscientious. Don't lose yourself in your career. If you're already lost, there are always ways to rediscover yourself. Reflect on what really brings you true joy, then run towards it. Make it happen. I hope I don't have to reinvent myself after this talk. I hope you've learned a few different strategies. The most important theme is to maintain connections, to become a part of and feel a part of that community. Remember, there's individual, organizational, and national strategies, but this is an active approach, and there's many ways to reinvent yourself. Thank you so much.
All right, thank you so much, Dr. Chetlen. That was great. For those of you that have just joined us, remember this is a SAM session. There's information on how to join in. You need to answer the questions during the session to get credit. Okay, so it's my pleasure now to introduce our next speaker, Dr. Sarkany, who's going to speak with us. He's coming from New York to speak with us about workplace solutions and strategies for preventing burnout.
Hi, everybody. Following Alison, we have a lot of things in common. She was taking it from the perspective of the individual. I'm going to be taking it from the perspective of the organization, but there really is a lot of overlap. I have no financial disclosures. So my objectives for this talk is discuss the components of burnout, which I'll do very quickly since we just did it, describe organizational strategies for preventing burnout, and describe what you as an individual can do in your workplace. So, as Alison said, burnout is a syndrome of exhaustion, detachment, depersonalization, lack of accomplishment. And it's definitely a two-step process where, there's the individual portion, but the organization is a major part, and some people would advocate that the organization is the bigger part. And I also want you to remember that burnout really affects everybody. So although we're talking to radiologists and maybe program coordinators, it affects technologists, it affects nurses, and if we keep in mind the team-based mentality that it really can affect everybody, I think it will make for a more successful endeavor. So some of these statistics were just discussed, but in the Medscape Lifestyle Report in 2017, so it showed 51% of general physician burnout, up 25% over 4 years. In the 2017 report, 49% of radiologists felt burnt out, and that's ranked 13 out of 30. So what are the reasons that the radiologists feel burnt out? So I thought this was an interesting statistic from the American Medical Group Association in a 2016 survey. 10 years ago, we were looking at one image every 20 seconds. Now we're looking at one image every 3 seconds. So we definitely feel like our work volume has increased significantly. Another aspect is bureaucracy. There's a lot more administrative work that each one of us has to do, whether it's compliance webinars or filling out forms. In addition, there's longer hours. 30, 40, 50 years ago, people finished work at 4 and went home. It doesn't exist like that anymore. Computerization. When I use this term, I mean all the frustrations we have with IT, when we have a new PAC station, or there's a new risk, or when things crash, and that slows us down. But it adds a lot of angst to our day. And the isolation or depersonalization is the concept that what PACs could do to you if you let it. But the biggest thing that causes burnout is, as I read in one of the articles, is you really feel like you're just a cog in the healthcare system. So who really cares? Now, obviously the individual cares because we don't like going through the feelings of burnout, but what I find is that we have to convince administrators and leadership that they should care. And lots of times when I've mentioned burnout or well-being, I get a lot of eye rolling. And I don't think they really realize that there's actually meaning behind it. And if you talk money, then their eyes open. So is there a financial argument to convince administrators to give resources to burnout? So ultimately, burnout can lead to turnover. And turnover means you gotta look for a new physician, and there's physician recruitment. In 2012, the Association of Staff Physician Recruiters said that lost yearly revenue for a single FTE was $990,000. And that was mostly based on loss of productivity while the person was gone and search expenses while you're trying to find the new FTE. So that by itself is a big chunk of change and should make the hospital, the organization, or the private practice rethink the way they're doing things. Some intangibles that you can't necessarily put money on is while you have somebody who's burning out or who's burnt out, the quality of the reports aren't going to be as good. They're going to just want to rush and get home as quickly as they can. Safety will become an issue. When you have some people who are burnt out, it becomes infectious. The negative attitudes will spread within the department. And you start producing a big monster. And so although it's one FTE is 990,000, it can turn into a much bigger problem. And there is a link between patient satisfaction and physician satisfaction. Many of us, when we're actually seeing our patients, if we go in As Alison said, 20% of the time, if you're passionate and you're going in and dealing with your patient, they're going to notice that. If they're going to see that it's just another cog, another image, another fluoro study, they're going to notice it. So what are organizational strategies for preventing burnout? And again, there's going to be a lot of overlap. The first thing that you have to remember is an organizational wellness strategy is not one size fits all. An academic center may need other things than a private practice. One academic center may need more things than a different one. So a needs assessment for your department or your organization is critical. We have to start the dialogue. So we started the dialogue today, but what's important is to start the dialogue in your institution. And what I find is the dialogue has to move down the chain, and everybody has to buy into that dialogue. And when you hit one of those individuals that doesn't buy in, it's time for an intervention, because all you need is that one individual to not make your plan a success. So everybody has to buy in, and those that don't buy in have to be re-educated. And interestingly enough, Stanford is the first academic center to have a chief wellness officer. And that's actually not a bad idea. So the next step, along with starting the dialogue, I think the most important thing in organizational strategy is your leadership. And the leadership is what's going to allow your plan to be successful. You need a good communicator. You have to make sure that the people on your team will be involved in the decision-making process. Each individual on the team will have unique talents. Somebody may not be a fast reader. Somebody might be a slower reader, but they have other talents. Somebody might be a great teacher, a great researcher. You have to look at each talent of the people in your group and make that a very positive experience. Another thing that I've noticed is in a lot of organizations, leadership is evaluated by leadership above them. And that doesn't make too much sense because they're not working with them on a day-to-day situation. I think it's really important not only that it should occur that way, there has to be accountability, but the people below the leaders should be able to evaluate the leaders. Just like we have 360-degree evaluations for our residents, the same should be true for our leaders. More leadership. Make a team-based approach. So as was discussed, you want to produce a community. You want a group of radiologists in the reading room. You want them to get along, turn around, say, oh, look at this great case I have. Or, what do you think about this? You know, this is an interesting case. You want to have faculty retreats. You want to have group activities after work. Feedback, one of my favorite things. You want to have a culture of feedback throughout the department every day. People shouldn't be scared to get constructive feedback, and you shouldn't be scared to give positive feedback. When I say review metrics, I don't mean just look at RVUs. There's a lot of intangibles, and there are articles written about all the other things that are important for our department, and the department has to reassess what they're looking at. So recently on Twitter, I saw this great example of a chairman acknowledging one of their professors for accomplishing something. And this was done in the public domain. It needs to be done in one way or the other. You have to give rewards, incentives, schedule flexibility, think outside of the box. But I'm telling you, if you just say congratulations, or, you know, that was a great find, you know, that can make a person's week, a month, and it costs no money, but it's extremely important. Increased efficiency. So we have long hours, our volume is tough to deal with, we got IT issues. So the goal is to decrease the clerical work, improve your IT. There is a concept, there has been some articles written about a reading room coordinator, where there's somebody in the reading room who takes the phone calls and tries to take care of everything that's not specific to the radiologist, and it's been very successful. Again, the group has to reassess the expectations and goals. Obviously, we want patient care, and we want that to be our priority, but you have to provide appropriate staffing And that might mean that you have to hire some new people. It might mean you have to go to administration and fight for another FTE if you're having an issue with burnout. Maybe you have to change the call obligations or change the hours depending on what one person will work better with. And as I said beforehand, relook at RVUs, salaries, hours. If you have a reassessment of the complete way you're running your organization, and you might change it completely compared to any other model, but if the attendings and the people you work with aren't burning out, you're going to be successful. We want to decrease isolation. So another thing I'm very interested in is patient-family-centered care. So there are a lot of opportunities for physicians to start getting involved with patients. Depending on the field that you're in, if you're in mammography or interventional, it's already happening. But there's plenty of other areas, ultrasound, fluoroscopy, even body imaging, that you can start interacting with patients. And in the talk I gave earlier, MGH has a consulting clinic where they actually meet with patients after the imaging is done to go over the imaging. There's a lot of nice ideas out there. And obviously increasing physician-to-physician interaction, interdisciplinary conferences, making yourself known and being part of the team. So it's not only going to tumor board, but offering suggestions of what needs to be done. Just like a patient wants self-control, a sense of control, we want a sense of control. So as was discussed, you want to give your faculty, your attendings, something that they're passionate about. So if they spend 20% of their time on something they're passionate about, you'll probably avoid a lot of negativity. And then decrease stress, as was discussed earlier. So the American Medical Association developed these 7 steps forward. And essentially what it is have a wellness champion, have a committee, do a survey to understand what's going on in your department, initiate an intervention, and then have a post-survey to see what's going on. Very simple and very intuitive, but will go a long way to having a successful plan. So this overlaps a little bit compared to the first discussion. What can you do as a radiologist when you're coming into work each day? What can you do to decrease the stress, decrease your chances of having burnout? So we can't do this during work, but you want to take breaks during the day. You know, lots of times we are very work-driven, partly because we want to get home, partly because we're stressed out because the list keeps on getting longer. But even if you take a couple breaks a day, 5, 10 minutes, go for a walk, that will go a long way for you feeling more comfortable with yourself and reading the cases. Even if it makes your day 30 minutes longer, it's going to give you great benefits and dividends. Be positive to your colleagues, be a team player. Discussions with like-minded colleagues. Originally I said, you know, have a self-help group, but really, you don't even have to do that. Just get together with people you're comfortable with and talk about experiences, when you made a mistake, how it made you feel, mindfulness, reflection, when a bad situation happened or even when a good situation happened. And lastly, improving your ergonomics on a day-to-day basis is important. So in summary, as we're talking these past couple of days, burnout is a real problem. The most important thing is for our leadership and our businesses to understand that it's a problem, and when you explain to them financially, they'll understand it. Leadership is the key to success. If you have good leadership, then your plan will be successful. Small things improve efficiency and your IT. Reassess the department goals and objectives are important. You want to make your attendings feel like they're a person and that they have some sense of control. And every single individual has to understand they're a critical component to the team, to the department, and to the care of the patient. Thank you.
All right, thanks so much. That was great. A great way to address the conditions in the coal mine and not just mindfulness in the canaries, as per an earlier discussion. Okay, so now it's my pleasure to introduce one of my mentors, Dr. Mark Mullins, who's going to be talking about mentoring skills, flipped mentoring, and how do I get mentored.
as somebody who grew up in the Appalachian Mountains, I can appreciate the coal mining analogy. So that was a good introduction. Good afternoon, everybody. I'm already on red, so I'm going to stop. I'm just kidding. All right. All right, so let's do a wellness. Stand up, stretch. You've been sitting there for a little bit. That's good. Do a little noodle. Do a little noodle. There you go. There you go. Now everybody leave. No, I'm just kidding. All right. So, so we're going to talk about mentoring here. I do collaborate with somebody on an RSNA grant, an education grant. I don't think it's relevant to this. The teacher in me says we need some of these, so they're the learning-centered learning objectives. I'm not going to read them to you. But basically, when I do these kind of talks, I talk in a very pragmatic and practical way. So, and I'm more than willing to take questions either now or offline. So one of the things that's made my life better is that we have a great media lab. Thank you all. I've got some media lab friends from Emory. So, and these are some iconographics. So basically, we've got some internal artists, and I just give her an idea. She says, just give me a word, and I'll come up with something and see if you like it. So I said mentorship, and there's mentorship. So I think this is awesome. I assume that this is the mentee, and that's the mentor, but I didn't ask for clarification, so I'm pretty sure that's it. So basically, how I view mentorship, it's a lifelong process. Things changed for me when I discovered that deans had mentors. Practically everybody that I've ever encountered in any position of success has had mentorship in the entire way. And for me, I consider all of it a two-way street. I learn from Kristen, just like she learns from me, and hopefully we're both better for it with the mentor-mentee relationship. So I encourage you to think that way. It is not inherently an age-related thing. It does have to do, in some cases, with life experiences and accomplishments, but it's not necessarily an age-related thing. So don't get hung up on that. I'm not an ageist kind of person in that regard. Ironically, I used to be the young person in the crowd, and as you can see, I'm no longer the young person in the crowd. So I believe in a mosaic mentorship model, so I think that you get different things from different people, maybe sometimes at the same time. And what I'm going to recommend to you in this regard is to be receptive to opportunity. The anecdote that I like to give around this is that I remember doing a project with an attending when I was a resident, and we went into a room and he said, block out 3 hours, and I'm not going to take any calls. All the authors are going to be in the room. We were all prepared, and at the end of this 3 hours, we will have a manuscript. And we did. And I cannot tell you how different that is from every other experience I've ever had writing a paper other than this person. But I've tried to take bits and pieces from this person and that experience. So I try to take those opportunities when they come, and I try to learn from different people. And through putting them all together, hopefully that kind of fits into my mentor-mentee approach. I pulled several things from the internet just in terms of defining mentorship and a few characteristics, and I'll talk about this. But I think there are some important adjectives that are in this definition here. And again, I'm not going to read to you. That way I'll lose 10% of you right off the bat. So I'm not going to read it to you. And, but you see the word collaborative. Basically it's a philosophic approach, like how do you fit together? And mutual. You see the word mutual there? I think it's a mutual relationship. This is not a one-way street. If you follow along on Twitter, one of the threads talks about the differences between being a coach or coaching as opposed to sponsor and what is sponsorship, and now we're talking about mentorship. So this is a mutual sort of relationship, and as I tell you, I think it's a bi-directional thing. You'll notice the word accountability there, like, different people play different roles in this. But I think one thing that's really lost on some people is the idea that the mentee, in my experience, is the person who drives this relationship, and they should drive this relationship. I have been assigned people as mentees over the course of time who have not done much, and they've not gotten much out of it. And I've had people who've done a lot with it and have gotten a lot out of it. So basically, I've discovered that, and I've discovered that with myself, that basically the mentee is going to drive the relationship. So when Paul asked me to Thank you for asking me to speak, Paul. So when Paul asked me to speak on this topic, not only am I very keen on the idea of mentorship in general, but in particular, this kind of flipped concept of the mentee driving the relationship. And I think that's one of the things I want to get along as a take-home goal. Hopefully, I don't have to convince anybody in here why it's important. I think it's actually sort of really a great vision that Acer had in terms of thinking how this fits into wellness. And once I started to see what the rest of the talks were in the session and the theme for the conference, I thought, it really does kind of fit in. It's interesting. I never thought about it till sort of it was framed that way, but I think it fits in very nicely to wellness as well. Just a few ground rules. I think above and beyond, the number one thing to get straight is what the ground rules are. And so that's a great first meeting to meet, so if you're mentee, as we all are, you get together and you say, okay, what are the ground rules here? What are we going to firewall off? What can we talk about? What can we not talk about? What are you comfortable talking about, as far as that goes? And just remember, you may be thinking of very formal mentor-mentee relationships, but there are lots of different ones: formal, informal, long-term, short-term, goal-directed, non-goal-directed. There's all sorts of different things. And so I want you to be thinking of all of those. And for example, if you pick someone who is in the same field as you, you may be at some points, collaborators, and at some point competitors. There may be that part of it. So what can you discuss? If someone's inherently over you in the org chart, when you talk to them, are you going to be seen as a complainer? Just these kind of things, like to understand where this is. And personally, I recommend that you have people outside of who's over you in the org chart as mentors in addition to the people that are over you in the org chart. The people who are over you in the org chart at some point are going to probably make decisions that are not in your best interest because they need to live up to their responsibility for that particular role. Classic thing is you're an attending in a division and you need your academic time, but they need to make sure things are covered. So you lose your academic day so that things are covered. So ordinarily, I'm sure that division director would say, yes, I'm supportive, and yes, I'm a mentor to them, and yes, I want them to succeed, but in that moment, it's kind of difficult. Now, to take one academic day that, okay, it's one academic day, but if it's a series of academic days, you lose your academic time, then it becomes sort of a problem. And you need some way to know if you're being abused, right? So basically, there's a great way to have somebody outside of your institution to know, this is not, you're not being treated well in terms of this regard. And it's also good to have people in your own institution that are outside of that pathway to know how things get done. Like, how do I get promoted here? How do I get this through the IRB? How do I get funding, get some seed funding here? How can I find someone to collaborate with as far as that goes? But these ground rules are important to try to figure out, who's doing what. Basically, this is pretty straightforward. I mean, you can work on your skills, and basically, I think I'm a better mentor now because I've been a mentee for a long time, and then I have some experience, right? So they say wisdom is experience with reflection. I've tried to achieve that as much as possible. I continue doing that. It's a lifelong aspirational goal, but I keep working on it. So basically, you can be a mentor. I'm sure many of you in the room are already mentors and mentees already, but basically, you can do that. Many of your locations have official mentorship programs. Our department, all of our new attendings get assigned a mentor outside of their domain, and it's a 2-year process, and there's a whole series of faculty development things that they do, including every other year retreat, and then it's followed up on. But as I've had, as I said, I've had some people assigned that did a lot with it, and some people haven't done much, so and everything in between. And here's something that comes up from time to time. What is effective mentorship? I mean, it kind of depends. I leave it up to the mentee of what they want to get out of it, and that's usually, like almost the very first thing after the ground rules that you talk about. Is like, what do you want to get out of this? And then try to figure out, is this a reasonable expectation? Is this something that we're going to figure out? And then, of course, time frames, right? And you kind of figure out how that works. So this I leave kind of open as to what is effective. You could attach this to objective success criteria. You could say H-index, you could say extramural funding, you could say, whatever, right? You can pick whatever you want to, and as far as I'm concerned, it's kind of up to the mentee to figure out, what they want to get out of that, what their goals are. And, if you see an analogy between this and doing research, I mean, there's a lot of this, right? So sit down, you say you want to do a project with someone, okay, what's your expected goal out of this? What's your time frame? What are our ground rules, that kind of thing. So I see a lot of parallels with that. And yes, I like to think about logic, so it kind of makes sense, makes me feel better to have a framework. So here's a few things that I saw from the internet that I thought were really good, and I want to highlight a few things. And now we're talking about the good mentee, right? So the good mentee, in particular, to take responsibility. I cannot overemphasize this. Ultimately, you are in control of your destiny as much as is humanly possible, right? So basically, it's you. Yes, a sponsor can open a lot of doors. Yes, a coach can help you through a particular point in time. And a mentor can help give you skills and can help you make decisions. But ultimately, it's your decision. So I'm sure maybe some of you have seen it from the mentor side before. Things like, you shouldn't sit there and tell people what to do. That's not really what a mentor does. You help that person look at all the different options and kind of work through it and figure out, to make their own decisions, right? To help them sort of figure that out. So again, it's take responsibility. And so part of that is follow-up, right? So when I meet with people, I give them small tasks, like either research projects or mentee. I give them small tasks and see what they do with it. And if they do something with that, then I'll build on that and we'll kind of go from there. But if they don't do anything with a small task, there's no reason in us wasting our time going further, right? So when you say that part and say, you take responsibility for it, you do the follow-up, you do the work, because basically, ultimately, it's your career, right? Come prepared, right? So this expression, garbage in, garbage out, one of the analogies here is, come to those meetings prepared and know kind of like what you want to talk about. I mean, if you want to get together and just have a beer, I love to do that. So please look me up, So that's cool. I'm fine with that. But if you want to get together and say you want to talk about how to, get involved in this, that, or the other thing, or how to publish something, that's something to focus on. Appreciation. I thought this tied in really nicely to the wellness. One of the keys, I think, one of the things that makes me feel better about my life is to really realize when things are good in my life and things have gone my way. All the time. The reason that we're all here is because we've not accepted all the good things. We've not sat on our laurels. We continue to burn the candle not only at both ends but in the middle, right? So we're seriously, we need to figure out how to get past that. And one of those things is appreciation. And over this process, the last few years of doing, people ask me to do mentorship talks, one of the things I realized was I hadn't thanked people who wrote letters for me for medical school. And it just dawned on me like a cold sweat, took me on at one point. And I tracked down, people, and I was just, I am embarrassed. I'm still embarrassed, this kind of stuff. But it's just that appreciation piece. The appreciation, that goes a long way, right? So appreciation made me feel better anyway. 6 Habits of Highly Effective Mentees, this kind of thing. I love this expression, strong beliefs weakly held. Be receptive to different ways of thinking about things. And then basically, be passionate about it, but be receptive to modifying your view accordingly, right? Follow up, I said that before, and do not make the mentor do all the work, right? All right, I cannot overemphasize that enough, right? That's not a mentor-mentee relationship in the way I want to think about it. That's basically an overlord telling you what to do, and you're the puppet, right? So if you like that analogy, fine. If that works for you, that's a different thing. But don't make the mentor do all the work. All right, so know what you want. You have to. It's like the song says, right? It's hard to get what you want if you don't know what you want, right? And so you have to find the right mentor, how it fits in. I like the Mosaic mentorship model. It's a two-way street, and it is that way probably the rest of your life. Maintain contact. Even if you've lost contact, come back and find contact. Come back to AUR. I try to volunteer every year as a mentor. See some of my former mentors here. Sometimes I hear from them in between. Listen. So listen, right, and communicate, that kind of thing. Follow through, know how to take criticism. If someone suggests that maybe how you handled something is not exactly optimal, it's how you do it. Try to do it professionally, but it's not necessarily a critique of you because maybe you missed something on a case. The only way not to miss stuff is not to read cases, right? So don't try to take it in the spirit in which it's meant. come prepared, be honest, definitely be honest, right? For more, I want to emphasize that in professionalism. And say thank you. It certainly makes me feel better to say thank you to everybody. I talked a little bit how we do it. Here's a reference in a collaborative thing that we did. It's online. You can take a look at that if you want. Totally up to you. And there's some suggested reading as well. So if you like that. And Eric is sitting right over there. Yeah, you want to take a picture of that, Eric? You're up there. So there you go. So I know we're going to do a panel afterwards. I'll take questions at that point. So I'll tie it up right now. Thank you.
All right, that was great. Thank you, Mark. And thank you for all your mentoring over the years. So now that I have the pleasure of introducing Dr. Michael Richardson from Washington, and he's going to talk a little bit about teaching skills at the workstation, tips and pearls. Oops, I thought it started. There we go.
Hi, I'm Mike Richardson. I have a few tips and pearls to share with you. Might be a good place to start. What do residents want? What do they value the most at the workstation? It's a nice study by Lamb et al. Recently where they looked at that. And residents value a lot of things, all of these variables right here, but the thing they value the most is good workstation teaching. So how do I try to do that? I've got a couple of areas I'd like to talk about. Artisanal teaching, tech tools, teaching students who are not radiology residents, and then a few caveats. So here we go. I think we all try to do artisanal teaching. That is, we want to try to tailor the education to the resident, what they need, what they want, who they are. First-year residents, they need a lot more than others. They need basics. They need basic anatomy. They need basic approaches to stuff, so we give them that. The senior residents, they're ready to stretch their wings a little bit, and we give them a little more responsibility, more nuance, more advanced imaging. If they have the bandwidth, academic projects that they can do. I'm a big fan of active learning, so I try to active the heck out of them. I'm a big fan of Socratic teaching. I try not to point the pointy end of the Socratic method too far into their flesh. Now, a big part of by being able to react to what they need is having this whole sack of tech tools by my side in the form of my iPad. So if they need if they have a particular lacuna in their knowledge, I usually have something I can drop into that. You probably heard anatomy is the queen of medicine. Well, we visit the queen daily, multiple times. This is one of my favorites. This essential anatomy basically puts a digital cadaver on my iPad that I can rotate around and flens apart to show whatever point I'm trying to make. Books. Members of our section have written a number of books. Most of them free or really cheap. Here we have some free books I've written on arthritis and tumors and other that we disseminate. Here, read this if you want to. My pal Jack Perino has written some ridiculously inexpensive $3 booklets which will take a resident who's right on the cusp of, I've never seen an MR before, they read it the night before, and they can generate an MR report that does not suck. Videos. We do a lot of arthrograms in our section. So a few years ago, our fellows and I put together videos of every single arthrogram we do. They're on our website. And first time they're coming on the service, so have you ever done a hip arthrogram? Why don't you look at this video, then let me know if you have any questions. It takes them through the whole steps from mixing the contrast to getting the needle out. Have a bunch of lectures on bone tumors. The International Skeletal Society and the Society of Skeletal Radiology recently made available this nice series of lectures, so I detect a particular lacuna in my resident's brain. I can point to maybe this, today at lunch, you should watch this video on metabolic bone disease. Lectures. We all have our canned lectures, so I keep those on the iPad, ready to go to pounce like a cheetah on a lacuna that needs filling. Digital teaching file. We have a big one with several thousand skeletal cases, so ready to throw those in as needed. Also, I'm a big fan of my Apple Pencil, so sometimes if I need to illustrate a particular concept like periosteal reaction, I can whip this out in about a minute and then hit the email too. Type in the resident's name and med students, whoever's there that would like a copy of this. I also have an article repository on my iPad ready to go, so common things that pop up like the difficult anatomy of the rotator interval. I've got a brilliant diagram that I did not write, but I really appreciate it. Some of the ligamentous anatomy of the finger, difficult area, hard to remember, great drawings in this particular article. I'm a physics wonk. My undergrad degree is in physics, so I like to drop in little physics items in my workstation teaching. And here's one thing I use on my iPad. It's called GarageBand. It's meant for making music, but did you realize that your brain and ear actually do Fourier analysis? So I demonstrate this to the residents. We have this diagram in mind, but there's a simple concept. Here I play this C major chord. This is what goes in your ear, this incomprehensible squiggle of waveforms. What your auditory cortex hears is 3 tones. You say, oh, I'm hearing a chord. And if you know about music, say that's a major chord. Or if you have perfect pitch, that's a C major chord, starting at middle C. I don't have that kind of perfect pitch, but isn't it wonderful that your brain can actually do Fourier analysis? We also have physical models. Sometimes we have tactile learners, so here you go, here's a spine, play with that. We have a 3D printer, and we're starting to print some of our own stuff to give to our residents and teach them stuff. Here's something I don't hear discussed often. We often have a lot of people in our reading room who are not radiology residents. They'll be fellows and residents and med students who are going into all sorts of things. And, I think clinicians' attitudes about us are shaped in their beginning years. And if their attitudes about us suck, then maybe there's something we should start doing. I think it's all too frequent they have this idea of us as these blind, malignant cave fish that sit down in the dark bowels of the hospital, sucking up all the RVUs and nutrients that rightfully belong to them. I don't want them to think of me that way. So I think this is a nice time at the workstation to model appropriate behavior among colleagues. So as these people come into our workroom, I'll introduce myself. Hi, where are you going? What are you going to be when you grow up? And there's 3 goals I would like to get across to them that I think are valuable. One is let them know what do radiologists actually do and what do we actually know. Secondly, what test do you order and under what circumstances? Third thing, the patient asks you about radiation dose. What are you going to tell them? So here's how and also use this particular teaching technique, the like to ask a friend technique. So imagine here, I've got an orthopedic resident and I've got a family practice resident reading out with us one day. So this case pops up. I'll talk to the family practice resident. What do you think? And if they get it, all glory to them. But when someone misses a case, what they have to do is ask a friend. Who would you like to ask? So they might ask the orthopedic resident. Says, well, that's obviously an anterior inferior dislocation. Okay, here's the post-production film. What do you think? Ortho residents, well, it looks okay to me. Would you like to ask a friend? Turn to the radiology resident who says, well, there is this Hill-Sachs lesion up here. Then we get an MR where perhaps even the ortho resident doesn't feel quite as certain. And the radiology resident gets to be the friend who tells them, oh, well, here's that Hill-Sachs lesion on here. Here's this big Bankart lesion. So I think modeling asking a friend is a good practice for working among colleagues in the future. What to order when? So I'll ask them, okay, where do you go on the internet to find out the answer to what test to order in a circumstance? And we all know our med students and residents and fellows have many years practice in sucking up, so they'll say, well, we'll call the radiologist. Yeah, sure you will, but thank you for saying so. But what if you can't get a hold of us? What do you do then? And they have various ideas of where they'd go. And I said, well, what about the biggest source of evidence-based radiology on the planet? ACR.org. So I'll point them to this website and turn them loose for about a minute. See if you can find that on their website. You know, anybody here from the ACR? Your site is almost ungoogleable. I'll give them about a minute of flailing trying to find something on here. Then I'll say, would you like to ask a friend? The radiology resident will say, he's trying to get you to say appropriateness criteria. So they will scour around and finally find that, and they're usually blown away. There's, as you all know, there are many of these for every one of their areas of interest. They say, wow, this is great. I didn't know this existed. Radiation dose. So imagine this. You've got a kid fell off of playground equipment, fell on an outstretched hand, it hurts. And you're suggesting, maybe we should order an x-ray. And the mom or the dad says, that's a lot of radiation. You really need to do that? So what are you going to tell them? And they say, well, I noticed these little radiation symbols here. So what are you going to tell them, that this exam has 3 radiation symbols? Oh, no, what that means is 1 to 10 millisieverts. Okay, what does that mean to you? And they say, I don't really know. So I think this is where the ACR site falls a little flat, and I recommend to them, anyone heard of XKCD? Brilliant internet comic dude, you should. So Google the following terms, XKCD and word radiation. And you get this amazing chart that Randall Munro put together. The blue squares here are background dose that everybody gets every day. Green stuff is diagnostic. Red stuff is terrible accident, you got way too much. The orange bars are 10 minutes at Chernobyl back in the day. And wondering, where did he source this material? Well, wackos like rsna.org and dubious areas like nrc.gov. So here we are back at our arm x-ray. Boy, that's a lot of little blue boxes. You could ask the patient or the patient's parents, well, how do you feel about bananas? Bananas? Yeah, because eating one banana gives you about this much, so arm x-ray is about 10 bananas worth. Oh. Do you ever fly them out to visit their grandparents? Oh yeah, twice a year. Well, each flight across country is about 40 hand x-rays. Oh. So this chart is brilliant at context, and that's something that we often don't have when we're talking to patients. I keep this on my iPad for a speed dial because I use it reasonably frequently. And it goes, here we were in diagnostic range. You can see a mammogram and a chest CT. They offer more. Some of the people in the room will be radiation workers, like the radiology resident, obviously. The ortho residents, the cardiology fellows, they're thinking, yeah, I'm going to spend a lot of time with that lead apron on. So this is the number of green squares you could get in a year. And you know that somewhere out there, some multiple of this will cause cancer. What do you think that multiple is? They'll guess, oh, maybe 100 or 1,000. Nope, it's about 2. So you don't want to get all those green squares. Wear your lead apron. Don't be a cowboy. So I offer this chart to you for your own teaching. I do have a few caveats. Now, for my teaching evaluations we get every 6 months or so, I realize that most of the residents find most of this palatable, and I think they learn something from it. But you do get pushback. So no matter what you try, how you try to innovate, you will get pushback. So just be prepared, take a deep breath, and realize that when you're trying to do artistical teaching, everybody has their own favorite learning style, and maybe the one you're offering isn't their favorite. So a number of our residents are really into active learning, and they thrive, and they love this stuff. Others prefer a more passive approach. Maybe you have this resident in your program. I know we do. Sometimes you get pushback. You're not giving enough time on basics. We also get too much time on basics. Geez, move it along. Socratic method, I think it's good to remember, how did that work out for Socrates? You've probably read about his final painful teaching evaluation. Sharing drawings, I send these out, spray them out like an Uzi to the people who are in the room, and occasionally get pushed back. Why are you sending all this stuff? I don't have time to read all this crap. Attempts at teaching innovative physics, I think most of the residents appreciate my efforts at this, but occasionally get things like, is this really going to be on the boards? Oh my God. Teaching students who are not radiology residents. I think most of our residents have pretty good insight, realize, oh, here I am working with my colleagues. These are my friends going forward in medicine here. This is good practice that they enjoy showing off what they know. But occasionally we'll get, why are you wasting this time on these bozos? God, it's all about me. I apologize to anyone who identifies himself as a bozo American. I mean, no disrespect. Teaching has to bow to practice demands. Some days your work list looks like this, so plenty of time to teach, and other days it looks like this and goes on for 3 pages, so you teach less. We get comments both ways. There's not enough teaching, and dude, you're doing too much teaching. We're getting behind on our work list. We try to walk that balance somehow. Now you might wonder, well, of course, if you're fitting your time teaching, you're not reading film, so your billable hours are going down. Know how much that is? John Moderator et al. Worked out the math on this a few years back, and it turns out it's about 50%. It turns out also the better job you do teaching, the more it drops. So, food for thought. Well, this has been a whirlwind tour through some of the crazy ideas I have for how to teach at a workstation. You're welcome to try these. If they work, let me know. If they don't work, suck it up. Try something else. You will get pushback, but hopefully these will be helpful to you. Thanks.
All right, thank you so much. That was great. Let's see if I close that. There we go. All right, I'm going to introduce our final speaker, Dr. Iyer, also from Washington, who's going to be talking to us about building a well-balanced educator's portfolio for promotion, some pearls and pitfalls.
Good afternoon. I'm a pediatric radiologist at Seattle Children's and the University of Washington. No disclosures to make. So my goal today is to talk about portfolios and really talk about some overarching purposes before drilling down into the more specifics of it. So the goal of a portfolio really is to provide this more nuanced or three-dimensional perspective of the educator as they're going up for promotion. And so in broader terms, what you're really trying to do is quantify the scope and quality of teaching proficiency by incorporating things like feedback, by incorporating things like teaching strengths, achievements, and any sort of trends over time are helpful. So I think it's important to list here, and I'll say it at the end, what it's not is a replacement for one CV, it's a supplement to a CV, because a portfolio that's going up for promotion at the packet is going to be comprised of your CV, your teaching portfolio, internal references, external references, et cetera. A lot of these metrics are going to be prioritized within the promotions process. I tend to think about it like a CV really is a great list of your individual accomplishments, and a portfolio is really good at reflecting back on the individual from the perspective of others. So it does, in my mind, provide some complementary information. So first tip I have is to find a template. Most institutions have a required format. You can find this from looking at a website or certainly administrative staff. Example portfolios may be available for review, so please find that if you can. I think it's important to be creative in general, but now is probably not the time to be creative in terms of finding the great format. Most institutions have a required format, so I might try to adhere to that if possible. Now is a great time to ask for advice, like most times. Recently promoted faculty is a great time to ask. It's a great resource because they may be more approachable to you because they may be closer in rank to you. But there's a wealth of resources out there, including the division chief, the department chair. Promotions committee members have certainly seen their share of successful and less than successful teaching portfolios. Now is a great time to get organized as well. I recommend having at least a couple copies, if not available, readily accessible. One is a hard copy. Depending on the institution, you may be required to provide an actual hard copy. This may be in the form of a 3-ring binder reminiscent of high school with dividers and subheadings, et cetera. And anytime you're providing a hard copy, it's important to have the digital copy available. Because a lot of these evaluations, or a lot of these documents may be retrievable from many years ago, I definitely recommend being on the safe side and providing multiple, or having multiple copies or redundant copies, either on a flash drive or hard drive. And I would definitely get used to, if you're not used to already, PDFing almost any document you get that you might include in your portfolio. A lot of these documents are going to be coming in a variety of formats, Word, Excel, PowerPoint, and converting them to PDF is not only an easy way to save them, but an easy way to print them as needed. It's a great place to leverage software. There's a lot of platforms that are available. I think one of the prior presenters mentioned Papers, which is a Mac proprietary one. That's a great one, but there's a lot of ones out there. The value is that it's really great at organizing a disparate collection of documents, and then trying to mine that information is really important because a lot of this information is going to be collated over several years, so it's a lot easier to find it through the software package than perhaps manually looking for it. I mentioned the basic portfolio formats. It's certainly good to have additional formats if you would desire to. Ones that certainly work well would be ones that can be viewed on a tablet. I've seen ones that are on websites, and you can basically send out a URL and include certain information depending on who the recipient is. I think these are great formats. I think as a replacement of a traditional format, I would probably recommend against that. However, there are some ancillary benefits to some of the more creative formats. For example, when you're getting your external references, for example, for promotion, you can send out these more creative versions of your portfolio formats for their review. Okay, so a lot of institutions have specific requirements for their portfolios. These are likely slightly different across institutions, but I think there are some common elements to keep in mind. First is the executive summary. This tends to be the first page or first 2 pages of your portfolio. I tend to think about this as a highlight reel. Basically, what you're trying to do is pack all of your, what you feel are your greatest accomplishments as a teacher into a concise document. The format may be variable depending on your institution. There may be a combination of text or bulleted. Definitely check with your template at your institution for that. I tend to think this is a great venue for describing your accomplishments that you feel most proud of, but that may be difficult to highlight in a CV. Again, reflections upon you from the perspective of others. I think it's important to think about when to write your executive summary. I tend to think it's analogous to when you write your conclusion or your introduction on a paper. Some people write it up front, some people write it in the end to sort of synthesize their thoughts. I think it's dealer's choice on that. Teaching philosophy, another great concise document. Generally it's about 1 to 2 pages. There's been some great talks here at AUR about teaching philosophy. I can't necessarily replicate that in the time I have, but just some points you might think about including. The first is your professional background or experience. For example, in a past life, you might have been a teacher or some type of educator, and that impacts how you educate trainees now. That type of experience would be important to elaborate upon in your philosophy. Certainly a good reflection on teacher-learner interactions. So for example, if you're a more formal educator versus an informal one, some people prefer teaching entirely in the reading room versus entirely in the classroom. And finally, what are your, or penultimate, I guess, your educational goals? So some people like to think about how to quantify their goals in a particular context. So for example, you may like to teach each trainee 2 to 3 teaching points each clinical workday. I think that's great. I think it's important just to talk about that within this philosophy statement. And then finally, any novel approaches, you may think it's fantastic to include as much audience response system because it can really engage an audience rather than just watching a bland PowerPoint. So those are something you may want to talk about here. Teaching activities, I would say this is probably the most variable component to any teaching portfolio. You can include any one of the following slides or all of them, but I think it's important, again, to check with your institutional requirements. You can include both clinical and lecture activities. So the goal here is to really kind of draw a line around or try to encapsulate or characterize this otherwise nebulous concept of teaching activities. That may be very difficult to do. I think it's important to at least meet some basic criteria, and so I suggest the following. Try to describe the activity in about a sentence or less of what you do. Who do you do it for? So who is your audience? And in what time frame do you do it? So your frequency or the duration of that activity. So this is an imaginary list, but I'd imagine your list looks pretty similar to this, where you might teach residents, I probably teach about 1 to 2 hours a day. Let's say you're thinking in your head. So how do you quantify that? Let's extrapolate the math on that. Let's say 5 to 10 hours a week. While I'm on clinical service, about 40 weeks per year, and I've been on staff, I don't know, about 10 years or so. So just a way to, again, characterize the activity, sentence or less, the audience which you're doing that for, and the duration. Some portfolios require you to include a sample of your presentation slides. So again, this is a nice example of PDFing PowerPoint. They may want to see what type of style you have when educating trainees or other physicians. Curriculum development, this would be a nice place also to include within teaching activities. This was a brochure that myself and a couple colleagues developed for a curriculum for primary care practitioners and pediatricians to how to order radiology studies and what they're looking for when they order that. So this was just a sample of the speaker panel as well as the speakers, certainly the date and time and location just to really just document it. We saw an example of this on Mike Richardson's fantastic presentation. I refer to our trainees to this all the time. It's great. It's an example of a website which, again, may be difficult to capture within a CV, but I think would really be important as educational content to really highlight in a teaching portfolio. So, for example, if you have an iPad format or a website, this would really lend itself to that format if you have teaching videos. You may include your URL certainly in your CV, but this would really expand on that. Okay, educational scholarship. So one of the mistakes that I see is, or maybe it's more partly right, would be to really just cut and paste what you have in your CV under your publications and include that in your portfolio. And I would say that's partly right, and I direct that more towards physician scientists. I think educational scholarship really focuses on educating the reader about a clinical topic or educating the reader about something specific to education. I think this probably isn't a great venue for basic science research. Obviously that's important, but I think the CV does cover that. So the types of publications one would include here might be good clinical review articles, certainly any case reports, for example, book chapters, self-assessment modules, MedEd portal, again, focusing on scholarship directed towards having the learner learn about some type of clinical activity or teaching them about education itself. mentorship. So I think we're starting to shift gears a little bit to focus on topics that, again, reflect directly on the promotion candidate as an educator, rather than that person just listing their accomplishments. And I think an important place to do this is mentorship. Again, your goal here is to try to draw a line around a nebulous concept that is mentorship. So one way to do this would be to list your proteges or your mentees, the duration of that relationship that you had with them, any educational outcomes you may have. Again, it's not required, but I think in this context it would be helpful to support your case. So any papers you may have or abstracts for conference presentations. And some people include a where are they now statement. So let's say a lot of your proteges are in private practice or a lot of them are in academia. I think it may be helpful for a committee member to see that. So an imaginary list, these are not real people, nor are they real projects, but it gets the idea across that you're trying to categorize the concept of mentors. Again, the mentee, the duration, any educational outcomes you may have, and then maybe where are they now. Okay. Evaluations, I think, are among the most critical aspects of the portfolio. I think it's important to include both quantitative and qualitative aspects, so scores and comments would be a way to think about it. Certainly trainees, I think evaluations from trainees are critically important because they're seeing you on a day-to-day basis. So what is this person like as an educator each and every day, as opposed to in the conference room once a month or at lectures such as this. Certainly you want evaluations when you can with all your lectures. So here at the University of Washington, we use a web-based software platform called MedHub. It uses Likert-style scoring, so probably similar to what you guys use at your home institutions. It incorporates comments, which I think are great. So I tend to, when I'm looking for feedback, I really focus on the comments. I tend to not entirely ignore the number scale, but I maybe focus on the comments. You can aggregate evaluations for a given date range. So let's say if the promotion committee wanted to see a date range from the prior year, or perhaps the last 5 years, this is a good platform to do that. And you can export this data separately as PDF format, so of course to store that and eventually place that in your portfolio. So conference evaluations, I'm sure your institution is like my institution in many ways, where at the end of each noon conference at Seattle Children's, the resident or fellow gets a sheet of paper at the end of the conference saying, hey, what did you think about the lecture? And they'll fill out Likert-style scoring as well as include some comments. So this is an evaluation form from several years ago. You can see the resident tended to like the lecture. There's some comments on the bottom. Those are partly legible, I would say. But again, extrapolating out at the math, you're looking at about, let's say, a half dozen or maybe even 10 residents or trainees per conference. And let's say you give conference once a month. So then you're looking at over 70 sheets of paper. So I think the natural question is, do I include all of this information in my portfolio or do I try to consolidate? I don't know that there's a right answer, but my preference and what I've seen done is to try to consolidate a little bit. So example here was a document that you can create where you list the academic year, the number of conference evaluations you're summarizing, and you're really just providing an average. So just giving the reader a sense about what kind of scores you're getting in various categories, so let's say out of 5, and just include that sort of detail. And include a bunch of comments if you can. Again, giving the reader, both quantitative and qualitative, an idea of kind of what you are doing on your noon conferences. And the main benefit is to reduce the amount of paperwork down from over 70 down to one legible sheet of paper. So if you're really eager to get more feedback on all your talks, whether or not to include in the teaching portfolio or not, there's a lot of great audience response system. You can embed these in your PowerPoint. Most of the vendors, I think, cost money, but a lot of times they have institutional accounts, so you can probably get those for free as if you're faculty. So you can get real-time feedback from all your talks. That feedback can be both quantitative and qualitative. You can get it within a matter of minutes. You can then obviously use the feedback, more importantly, to improve your talks, but you can certainly export that information as feedback for your portfolio as needed. So feedback, emails, and letters, I include this as an optional section. I tend to think these can give a candid perspective of the person as an educator. This is just an example letter what one might receive from a residency program director, which I think is great to include. Certainly any letter from any protege or mentee would be great. You can certainly go overboard with this. I would recommend not going overboard with this, but it's an optional section. But again, it can give you it can add a personal touch to a portfolio as needed. Okay, a couple parting thoughts. Quantity versus quality, I think this is always a tough balancing act. Promotions committee have a lot of candidates and they have a finite time to review them. And so it's my opinion that more is not always better. I personally think it's a small set of well-chosen documents is far preferred over this large unfiltered collection of documents you may pile on somebody's desk to review. Again, it's worth reiterating, the portfolio is just generally one component for a promotions packet that again will include a CV and references. Starting early, I think, is important. I tend to recommend about 6 to 12 months prior to going up for promotion, or at least submitting your portfolio for review, because you need some time to collect a lot of this material, because a lot of this is difficult to obtain, like evaluations from many years ago. You also need some time to get on people's calendars, because it might be tough to track down the chair to ask him or her about your promotion. And in that time period, I think it's important to spend time on critical components. There's not a lot you can do to change teaching evaluations you got from 6 years ago. I think it's important to mine that data and synthesize it and display it accordingly. But there is something you can do in terms of some of those documents that the committee is going to be spending probably the most time on, which would be the executive summary and teaching philosophy. And that's one way to put your best foot forward when you're going up for promotion. Thanks so much for your time.